Welcome back, guys. Now in this video let's discuss about lymphoma. So let's write lymphoma. Okay, so what exactly do I mean by lymphoma? Here this word lymph, it's standing for lymphocytes. Okay, it's standing for lymphocytes, the B lymphocytes and the T lymphocytes, and oma stands for a mass. Now actually lymphoma is a cancer, it's a neoplastic proliferation of the cells, it's a neoplasia. And these neoplastic cells, the cancerous cells, now they are not just simply traveling within the blood. If they are simply traveling within the blood, we are going to call it as a leukemia. Leukemia is the cancer of the white cells. Now the same white cells, lymphocytes, they are going to form a mass. If they are forming a mass, then we are going to call it as lymphoma. So let's write here, it's a neoplastic proliferation of which cells? Lymphoid cells. Lymphoid cells means, you know, the lymphoid cells means the B lymphocytes and the T lymphocytes. It's a neoplastic proliferation of the lymphoid cells that forms a mass. This is the keyword, mass. Okay, so where they are going to form a mass? This mass can be present in a lymph node. Okay, the lymph nodes will be enlarged, lymphadenopathy can be seen, lymph node and some other organs. Okay, that's it. Now this lymphoma, it's of how many types, sir? The lymphoma, it is divided into two types. What are the two types? Hodgkin's lymphoma, Hodgkin's, and non-Hodgkin's. Okay, Hodgkin's lymphoma and non-Hodgkin's lymphoma. See, out of this, non-Hodgkin's lymphomas are most common. Hodgkin's lymphomas are also common, but 40%, less than the non-Hodgkin's lymphoma. Non-Hodgkin's lymphomas are most common, and in this lymphomas topic, we are also mainly going to concentrate on the non-Hodgkin's lymphomas only. Why? Because they are more important for the exam. Okay. Now, having said that, let's begin with the non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma. So simply let's call it as a NHL. Now non-Hodgkin's lymphomas are of how many types? They are classified into many different types. There are different classifications for the non-Hodgkin's lymphomas. For example, whether the lymphoma is formed by a B cell or a T cell. Okay, yes, there is a non-Hodgkin's lymphoma. Whether this mass, this cancer, it's because of a B lymphocyte or is it because of a T lymphocyte? Classifications are there. Okay, based on the cell size. Whether the neoplastic cells are small cells, small B cells, or intermediate size cells, or large B cells. Okay, so based on the size of the cells also, there is classification. Okay, based on cytogenetic abnormalities. Okay, cytogenetic abnormalities. There is a classification based on surface markers. So what I am trying to put into your mind is, sir, right now we are going to discuss about the non-Hodgkin's lymphomas, no doubt. Non-Hodgkin's lymphomas are divided into many types. There are different classifications. The classifications are based on whether the non-Hodgkin's lymphoma is because of the B cell or it is because of the T cell, whether the sizes of the cell are large, big or small. Okay, based on the cytogenetic abnormalities, based on the surface markers on the cells, the classification is of different types. But in this video, I will be mainly concentrating on the cell size. Okay, the non-Hodgkin's lymphomas, they are classified based on the cell size. So it will be easy for you to understand also. Many books and many teachers follow this classification, so it's very easy for you to understand. Okay, based on the cell size. So I'm going to say that there are certain non-Hodgkin's lymphomas where the size of the cells are going to be small. I will be saying small neoplastic proliferation of the small B cells, neoplastic proliferation of the intermediate size B cells, neoplastic proliferation of the large B cells. So based on the size of the cell, the classification is going to be there. Okay, so now let's write here itself. So non-Hodgkin's lymphomas, first small, let's write here. Okay, small B cell, small B cell non-Hodgkin's lymphomas. What are the examples? Examples are follicular. lymphoma. Okay, follicular lymphoma. Second one is mantle cell lymphoma. Okay, mantle cell lymphoma, marginal zone lymphoma. See, all these three, follicular lymphoma, mantle cell lymphoma, marginal zone lymphoma, okay, all these three are non-Hodgkin's lymphomas, no doubt. They are coming under small B cell lymphomas, which means, so here, first of all, the things what I want you to know is, all these three lymphomas are the cancer of which cells? They are cancer of B cells. Okay, they are the cancer of B cells. And the size of the B cells is going to be small. Now, where this lymphoma is happening? See, follicles, mantle zone and marginal zone, these are the regions of a lymph node. Okay, all these are the regions of the lymph node. So, you should have a basic understanding that if I take a lymph node, for example, like this, in the lymph node, the outermost region is going to be called as the cortex. The outermost region is called as the cortex. Now, in this cortex, what you are going to have? You are going to have the follicles. Okay, for example, here are the follicles. Okay, so in the follicles, who is going to be there? The B cells are going to be there. Now, if you have too much proliferation of the follicles, too much proliferation of the follicles, then it is called as a follicular lymphoma. Surrounding that follicles, there is a region going to be called as the mantle region. Okay, surrounding the follicles, there is a region called as mantle. Even in this mantle, B cells are going to be there. Now, if there is expansion of the mantle, okay, there is expansion of the mantle because of the neoplastic proliferation of the small B cells. So, the small B cells which are present in the mantle region is neoplastically getting proliferated, making the mantle zone to expand. So, that is going to cause a lymphadenopathy, non-Hodgkin's lymphoma, as simple as that. Okay. Next, surrounding this region, there is going to be called as a marginal zone. Okay, usually marginal zone is not going to be there until unless if there is a chronic inflammatory condition. So, there is a marginal zone, okay, in the lymph node, that too in the cortex only. Now, if this marginal zone is showing the neoplastic proliferation of the B cells, small B cells are getting neoplastically proliferated, and there is expansion of this marginal zone, then it is called as a marginal zone lymphoma. So, at the end of the day, the point which I want you to know is, sir, small B cell examples are follicular cell, mantle cell, marginal zone lymphoma. There is one more thing, okay, just keep this thing in mind. There is something called as small lymphocytic lymphoma. Okay, small lymphocytic lymphoma, also called as CLL, okay, chronic lymphocytic lymphoma. Chronic lymphocytic lymphoma. In the chronic leukemias topic, I have discussed chronic lymphocytic leukemia. It's also a cancer of the B cells. It's also going to form the lymphoma. It can form the lymphoma in the lymph nodes. So just keep this point in mind. SLL or CLL, it's also a type of non-Hodgkin's lymphoma where the neoplastic cells are going to be small in size. Okay. So small B cell lymphomas are completed. Next, intermediate sized B cells. Okay, intermediate size B cells. Example is Burkitt's lymphoma. Okay, Burkitt lymphoma. So it's a very important question where African child is given with enlarged, okay, the lymph nodes near the jaw region. We will discuss about that. Burkitt's lymphoma. Yes, it's a B cell lymphoma, no doubt. But the size of the B cells are going to be intermediate in size. The last one is large, okay, B cells. So the lymphoma where the size of the B cells is going to be very large. Example is diffuse, large B cell lymphoma. Okay, which is a DLBCL, diffuse large B cell lymphoma. From this, you can say, I have given you an idea. Non-Hodgkin's lymphomas, mainly non-Hodgkin's lymphomas are going to be occurring with the B cell, okay, with the B cell. Here I have divided different types of lymphomas based on the size of the B cells, small B cells, intermediate size B cells and large B cells. Now, having said that, first let's discuss about the differences between the Hodgkin's lymphoma and non-Hodgkin's lymphoma. Okay. Before going to discuss about the non-Hodgkin's lymphoma, before going to enter into these non-Hodgkin's varieties, let's see some important differences between what is a Hodgkin's lymphoma and what is a non-Hodgkin's lymphoma. So here, let me write non-Hodgkin's lymphoma, here Hodgkin's lymphoma. Who is more common? 60% of the time non-Hodgkin's lymphoma is common, 40% of the time it is Hodgkin's lymphoma. Now in non-Hodgkin's lymphoma, the cancer of which cells? It's a lymphoma and lymphocytes. Okay, the cancerous cells, okay, the neoplastic cells are going to be lymphocytes. In Hodgkin's lymphoma, the neoplastic cells are going to be called as, there is neoplastically what you can see is the Reed-Sternberg cells. Okay, Reed-Sternberg cells. Okay, Reed-Sternberg cells are going to be seen. Okay, Reed-Sternberg cells are going to be seen in the mass. What exactly are the Reed-Sternberg cells? I will explain you. Okay, which is going to have owl-shaped nuclei, that we will discuss. Next, if you look at the composition, okay, the composition of the mass. In non-Hodgkin's lymphomas, it's totally cancerous cells. So the neoplastically proliferated cancerous cells. Whole mass is going to be the B cells or the T cells. Okay, so composition is going to be the lymphoid cells. Lymphoid cells. What composition? Okay, it's all the lymphoid cells. Here in Hodgkin's lymphoma, the majority of the mass, majority of that cancer is by the inflammatory cells. Okay, inflammatory infiltrate, the reactive inflammatory cells. Okay, reactive inflammatory cells. Okay, reactive inflammatory cells are going to be mainly seen along with fibrosis. Okay, along with the fibrosis. Next, how the patients are going to present, the clinical features in both the conditions. It doesn't matter whether it's Hodgkin's lymphoma or non-Hodgkin's lymphoma, there is going to be lymphadenopathy. Okay, painless lymphadenopathy. Painless lymphadenopathy. Here also painless lymphadenopathy is going to be seen along with some B symptoms like fever, chills. Okay, sweating is going to be seen in the night. Same thing. The most important point which I want you to know is spread. Okay, this is the most important point. See, non-Hodgkin's lymphomas are often extranodal, means not the lymph nodes but the other sites. Okay, sites other than the lymph nodes are going to be most commonly involved in the non-Hodgkin's lymphomas. Yes, of course, lymph nodes are involved, but mostly extranodal. Okay, diffuse means there is no particular order. Okay, it's not like first this nodes, later this, later this. There is no connection. Okay, it's not like a sequence. Okay, non-Hodgkin's lymphomas do not follow a sequence. Okay, first cervical lymph nodes, axillary lymph nodes, not something like that. Okay, it can be diffuse. Any lymph node can be affected. Okay, first this node, this node, this node. In any, like it's a random, diffuse. Often, extranodal involvement can be seen. Not just the lymph node, even other tissues can be affected. Okay, but Hodgkin's lymphoma, when I am discussing about the Hodgkin's lymphoma, there is a continuous involvement. The lymph nodes are going to be affected in a continuous manner. Okay, so there is continuous involvement. The two, only lymph nodes are going to be affected, rarely extranodal. Okay, rarely extranodal. Rarely extranodal involvement is going to be seen. Now, what about the leukemic phase? So, what does I mean by leukemic phase is, see, if I am talking about leukemia, for example, I have discussed about different types of leukemia, acute leukemia, chronic leukemia. Let me give you an example. Leukemia, I am talking about a leukemia. Can this leukemia, for example, chronic lymphocytic leukemia or something, the patient is having BALL, TAL, something, he is having leukemia. Now this leukemia, can it have lymphoma phase? Can it have lymphoma phase? Or a lymphoma, can it have leukemic phase? Possible. See, most of the time it's possible. Like most of the time it's possible. See, for example, the patient is suffering with a leukemia. Leukemia means what? It's a neoplastic proliferation of the white cells. The more and more white cells are there. Okay. Now these white cells, where they are present? They are present in the blood. Okay, they are present in the blood, but they are not forming the mass. Leukemia. Now what can happen is that these white cells, they can go into the tissues, and in the tissues they can start to proliferate and it can form a mass. So a leukemia person can develop lymphoma. He can have a lymphoma phase. Possible. And the lymphoma patient also, lymphoma patient means he is having a neoplastic proliferation of the white cells in a tissue, for example like a lymph node and a spleen and some other tissue. Now these cells, they can come up into the bloodstream and the patient can have a leukemic phase also. So both are possible. A leukemia patient can have the lymphoma phase and a lymphoma patient can have a leukemic phase. But when I am discussing about the differences between non-Hodgkin's lymphoma and Hodgkin's lymphoma, this patient leukemic in non-Hodgkin's lymphoma, leukemic phase can occur, yes. But Hodgkin's lymphoma, leukemic phase is not going to occur. With Hodgkin's type of lymphomas, okay, you don't know any examples, but Hodgkin's lymphoma usually do not cause any leukemia, does not occur. Okay, non-Hodgkin's lymphomas can cause leukemias, but not the Hodgkin's lymphomas. So having said that, now let's discuss about the non-Hodgkin's lymphoma. So now you should tell me, first we have to start with what? We have to start with the small B cell lymphomas, small B cell lymphomas. What are the examples of small B cell lymphomas? Follicular lymphoma, mantle zone lymphoma, marginal zone lymphoma, okay, these things. So now let's start with the follicular lymphoma. Okay, so now tell me, first point, it's a cancer of which cells? It's a neoplastic proliferation of, NP means neoplastic proliferation. It's a neoplastic proliferation of small B cells. Okay, small B cells, which, how do I identify these cells, sir? These cells are CD20 positive. Okay, CD B cells, we know it. Okay, from beginning we are studying that B cells are going to have the CD10, okay, CD19, CD20, CD21, something like that. So these cells, neoplastic proliferation of the small B cells. Small B cells means almost like a mature cells, which are CD20 positive. Now, why the name follicular? I have said you. Now, in these lymphomas, there is more proliferation of the follicles. A follicular growth is going to be seen. Follicular proliferation is going to be seen in the cortical region of a lymph node, which is going to form a mass, lymphadenopathy. So, these neoplastically proliferated small B cells are going to form follicles. Forms follicles that looks like nodules. Okay, now let me show you an image. So look here. Now look at this. Now in this lymph node, what you can see is this follicles. In the lymph node, there is so many follicles. There are so many follicles that are going to be seen within the lymph node. It's a follicular lymphoma. Simple. Follicular lymphoma, small B cells. It's a B cell cancer. Okay. Now you can ask me why. And it is seen in which people? See, it is going to be present in late adulthood. Presents in late adulthood. Okay, the patient is going to have painless lymphadenopathy. The problem in this condition, what exactly is the problem, sir? This follicular lymphoma, what exactly is happening is a translocation between 14 and 18 chromosomes. Translocation 14-18 is the one which drives this lymphoma. Now, if you ask me what is the problem in this translocation, see on chromosome number 14, there is a locus, there is a gene for immunoglobulin heavy chain, Ig heavy chain, which is very active locus. That segment, that part of the chromosome number 14 is very highly active. Okay, on the chromosome number 18, there is a gene which is called as BCL2. BCL2 is anti-apoptotic. Okay, it is anti-apoptotic, which doesn't allow the apoptosis to occur. Okay. Now what I want you to know is, this point on chromosome number 14, there is a region called as a immunoglobulin heavy chain gene, which is highly active, transcriptionally highly active. That region is highly active. Now what is happening? So this BCL2 region on chromosome number 18 is going to get breakaway. Okay, this region, okay, 18 is going to get breakaway, and it is going to come and attach to the 14th chromosome. Okay, now for example, let me give you this is the chromosome number 14. Okay, chromosome number 14. Now there is this region, okay, which, okay, let me highlight with this color. So this locus is for immunoglobulin gene heavy chain. Okay, heavy chain. Okay, now what's happening? So this part is getting broken. Okay, see, this area of the chromosome number 14 is got broken down. Now that area got broken down, separated. Now what is happening from the chromosome number 18? Okay, from the chromosome number 18, this is the 18th chromosome. It's coming and getting attached here. Okay, chromosome number 18 is coming and getting attached here. This part which I am showing in the pink color, this is chromosome number 18th part is coming and getting attached here. So what is this gene that is located here? This is BCL2 locus. This is the BCL2 gene. So what happens? Now this BCL2 is coming and getting attached to a region which is highly transcriptionally active. So now this BCL2 expression is also going to be increased in the cell. The BCL2 expression is getting increased. So more and more BCL2 is there. We know the BCL2 prevents the leakage of cytochrome C from the mitochondria. BCL2, it prevents the, let me write here, it prevents leakage of cytochrome C. It prevents the leakage of the cytochrome C from the mitochondria. Once the cytochrome C is leaked, means apoptosis will happen. Now what is happening? There is more BCL2, which means it doesn't allow the cytochrome C to leak into the cytoplasm. So this B cells, this is happening within the B cells. Okay, so the B cells are not going to die. Okay, the B cells are not going to die. So B cells are going to continuously proliferating. Actually, B cells are supposed to die. In the lymph node, the B cells have to train themselves. They have to identify what is self and what is non-self. Okay, so those cells which are identifying, see, for example, imagine there is this B cell which is identifying self as a non-self. So that B cell should be immediately terminated. We actually want to have the apoptosis in that particular B cell, which is bad, which is recognizing self as a non-self and attacking, so leading to the autoimmune diseases. So that B cell should be dying. So in the lymph node, many B cells are kept on dying. Okay, and that's good. But because of this translocation, 14-18 translocation, the B cells are not going to die. So they are going to continuously just stay in that place and going to form the follicles. So the lymph node is going to get enlarged, follicular cell lymphoma. So the only point what I want you to know is, so the patients are going to have translocation 14-18 because of the overexpression of the BCL2, okay, which inhibits the apoptosis. Now, what is the treatment for this condition? The important point that there is a drug which is called as anti-CD20. Okay, these B cells are going to be positive for the CD20, right? So we have developed an antibody which is against the CD20. Anti-CD20 antibodies. What is that name? Rituximab. Okay, so rituximab is used for the treatment of follicular cell lymphoma. That's the important point which I want you to know. Now, one more thing is, these patients, okay, who is having this follicular lymphoma, they are at a risk of, okay, they are at a risk of developing, okay, additional mutations. They can develop the additional mutations and they can go into diffuse large B cell lymphoma. Okay, they can develop diffuse large B cell lymphoma. So what I want you to know is, see, imagine there is a person, you know, a case of a patient who is having follicular lymphoma. You know, this fellow is having follicular lymphoma, sir. Now suddenly one of his lymph node is getting enlarged very rapidly. Okay, suddenly one of the lymph node is getting enlarged very rapidly. Then you can say this patient might have gone to diffuse DLBCL, diffuse large B cell lymphoma. Okay, so if follicular lymphoma is converted into diffuse large B cell lymphoma, that's important point which I want you to know. In chronic leukemias also I have discussed, there is one leukemia called as a CLL or SLL, chronic lymphocytic leukemia or small lymphocytic lymphoma, okay, where you can see the smudge cells. In yesterday's class we have discussed. So that can also develop into, in yesterday's class I have discussed, that's why I am adding here, not in yesterday's class, in that chronic leukemia video. In CLL, if your patient is having CLL, he can develop the additional mutations and he can develop the diffuse large cell lymphoma, okay, diffuse large B-cell lymphoma. So done, sir. Now, how to differentiate this condition? See, let me tell you something. If imagine there is a patient, okay, let's put it this way. Imagine there is a patient who is having some infection, okay, who is having some acute infection. Even in this person's lymph nodes, because of this acute infection, there can be follicular expansion. The follicles, the number of follicles can be increased. There is a reactive, okay, reactive hyperplasia of the follicles can be seen. Then how to differentiate whether the patient is having lymphoma or whether the patient is having some acute infection that is leading to this follicular enlargement or follicular hyperplasia? How to differentiate between these two? So let me write here, follicular lymphoma must be differentiated from what? From reactive follicular hyperplasia that is seen in acute infections. How to differentiate? See, in follicular lymphoma, first of all, okay, if it is follicular lymphoma, in the entire lymph node there is going to be total follicles everywhere. In the lymph node there is follicles everywhere. So there is a distortion in the architecture of the lymph node. The entire lymph node architecture is totally distorted. It should be actually like cortex, there should be paracortex and sinusoid should be there. So now it is not something like that. If you take a lymph node, everywhere it's follicle everywhere. Okay, so there is a distortion of architecture of lymph nodes that is seen in the follicular lymphoma, but it is not seen in reactive follicular hyperplasia. It's not seen. The second thing is, actually in a normal lymph node, okay, in a normal healthy lymph node, follicles are going to be there, and in the follicles I have said you the B cells are getting trained, and most of the B cells they will fail. They do not recognize, actually they will undergo somatic hypermutations, so that they will be by this process, simple, they should recognize what is self and what is non-self, what is our own antigens, what are the foreign antigens. Okay, see, most of the lymphocytes will fail, so that B lymphocytes should be eliminated. That B lymphocytes will undergo apoptosis. At the end of the apoptosis, you know, apoptotic bodies are going to get formed, and those apoptotic bodies should be removed by the macrophages. Okay, in a normal healthy individual like you and me, lymph nodes are going to have follicles, and in the follicles many B cells are going to die. They will undergo apoptosis, and that apoptotic areas will be cleared by the macrophages. So those areas are called as, those macrophages are called as tingible body macrophages. Okay, let me show you. For example, look here. See, here you can see the macrophage, these cleared areas. Okay, so in these areas there is a macrophage present, and this macrophage, it is kept on eating the debris. The debris is nothing but the apoptotic cells. Okay, so these macrophages are called as tingible body macrophages, which are seen in a normal follicular hyperplasia, reactive follicular hyperplasia. But I have said you, because of this 14-18 translocation, BCL2 overexpression, now will the B lymphocytes die in follicular hyperplasia? If there is follicular lymphoma, do you think the B cells are going to die? No. So do you think apoptosis will happen? No. So do you think tingible body macrophages are going to be seen? No. So no tingible body macrophages seen in follicular lymphoma. No tingible body macrophages. Okay, no tingible body macrophages are seen. Next, it is normally seen in reactive follicular hyperplasia. Next, these cells, you know it, these B cells, what you can see, BCL2 overexpression. Okay, normally B cells do not show any BCL expression, sir. Okay, B cells, if they are properly trained, okay, they are going to allowed to live. If the B cells are not properly trained, they have to undergo apoptosis, so BCL2 expression is not going to be seen. But in these cells, BCL2 overexpression, lots and lots of BCL2 is going to be there, which is preventing the leakage of the cytochrome C from the mitochondria, which prevents the apoptosis. That's the one thing. And here in follicular lymphoma, it's a cancer. So these cancerous cells are going to look the same way. There is no antigenic diversity. Okay, they do not have no antigenic diversity. All antibodies, whatever are going to be produced, they are going to be of same type. So there is a monoclonality. They are of same type. Okay, all the cancer cells, you know, the cancer cells, the basic principle, they have that monoclonality. Okay, monoclonal. All are going to look the same. But if it is a reactive follicular hyperplasia, there is going to be a very wide range of diversity. Okay, that is not going to be seen. So here, this follicular lymphoma, in follicular lymphoma, there is going to be monoclonality. But in reactive hyperplasia, there is going to be polyclonality. So with this, we have completed follicular lymphoma. The important points which I want you to know regarding the follicular lymphoma, the follicles are going to be expanded. You have seen the image that I have shown, and the translocation is going to be 14-18 translocation, where the BCL2 overexpression is going to be seen. The treatment is going to be done with anti-CD20 antibodies. The drug is called as a rituximab. These patients are at risk of developing diffuse large B-cell lymphoma, DLBCL. How to identify that? When this patient, a known case of follicular lymphoma, suddenly, okay, a late adulthood, somewhere around 25-30 years, this patient suddenly have enlarging lymph node, then you should suspect that this patient have developed diffuse large B-cell lymphoma. Okay, so how to differentiate it from follicular hyperplasia, reactive follicular hyperplasia? These four things: distortion of the architecture, overexpression of the BCL2, monoclonality is going to be seen, and no tingible body macrophages. No tingible body macrophages. Okay. Now after this, let's discuss about mantle cell lymphoma. Mantle cell lymphoma. Now, so what exactly happening in the mantle cell lymphoma? You should not forget one thing. Mantle cell lymphoma, it's a, yes, of course, non-Hodgkin's lymphoma. It's a cancer of which cells? It's a neoplastic proliferation of, okay, neoplastic proliferation of small B cells. Okay, small B cells that are CD20 positive. Again, small B cells only. But which region of the lymph node is going to be specially getting expanded? It's the mantle region. Okay, surrounding the follicles, you are going to have a mantle. That mantle region is going to be expanding. Okay, now how the patient is going to present? Same, painless. Lymphadenopathy is going to be seen. Okay, but what is the reason for this mantle cell lymphoma? Is the translocation. Again, translocation 11-14 translocation. Okay, 11-14 translocation. Okay, translocation 11-14. So what exactly is the problem with that 11-14 translocation? The translocation is, the exact problem is, you know it. On 14th chromosome, on chromosome number 14, there is immunoglobulin gene, heavy chain. Okay, gene is going to be there, which is highly active. On chromosome number 11, there is a gene for cyclin D1. Cyclin D1 gene is present on chromosome number 11. So this cyclin D1 gene is going to come and getting attached. It's getting attached to the chromosome number 14. So now the cyclin D overexpression. Okay, cyclin D1 overexpression. When there is cyclin D1 overexpression that is seen in these B cells, there is going to be overgrowth. Okay, it increases the growth, promotes the growth of the cells, and it shifts. For example, normally the cells are in G1. Okay, G1 phase, you know it, G1, yes, G2. This overexpression of the cyclin D1 promotes the cell from G1 phase to the S phase, means cell division, synthesis phase, DNA replication followed by G2 followed by cell division. Okay, so cyclin D overexpression is the one responsible for the mantle cell lymphoma, facilitating the neoplastic proliferation. The cells are getting neoplastically proliferated. Okay, so translocation there, follicular lymphoma, it is 14-18 translocation. Here mantle cell lymphoma, the translocation is going to be 11, 14 translocation. There it is BCL2 overexpression. Here it is cyclin D1 overexpression. So these are enough regarding the mantle cell lymphoma. After mantle cell lymphoma, let's discuss about the marginal zone lymphoma. Okay, marginal zone lymphoma. So what exactly is the problem with the marginal zone lymphoma? Here also, it's a mantle cell, follicular cell, I should say follicular lymphoma, marginal zone lymphoma, mantle lymphoma, all these are cancers of neoplastic proliferation of small B cells, which are again CD20 positive. Now what exactly is the problem with the marginal zone lymphoma? See here, this marginal zone lymphomas, they are associated with chronic inflammations. Whenever there is chronic inflammation in the body, okay, chronic inflammation, these marginal zones are going to be expanded. Normally marginal zones are not going to be there in the lymph node until unless if there is some chronic inflammation happening in the body. So that marginal zones are going to be formed, which are again with the B cells only. B cells are going to be there. So they are associated with the chronic inflammatory conditions. So what are the examples of the chronic inflammatory conditions? Like Hashimoto's thyroiditis. Okay, Hashimoto thyroiditis or Sjogren syndrome. Okay, Sjogren syndrome, Hashimoto's thyroiditis or H. pylori gastritis. So it's not the translocations. Okay, it's not the translocations, it's the chronic inflammatory conditions. In chronic inflammatory conditions, the marginal zones are going to be expanded. Now in this marginal zone, if the marginal zones are getting expanded, that's going to cause the marginal zone lymphoma. The one important point which I want you to know is there is something called as a gastric maltoma. Actually, gastric maltoma usually seen as a complication of this H. pylori. Okay, H. pylori, those persons who are having H. pylori gastritis, chronic gastritis, these individuals are at risk of getting a cancer which is called as a gastric maltoma. This gastric maltoma is a it's a subtype of marginal zone lymphoma. It's nothing but a marginal zone lymphoma. Okay, so done. So I have discussed about the three lymphomas where the cancer is because of the small B cells. Follicular lymphoma is completed. Next, mantle cell lymphoma and marginal zone lymphoma. Now after this, let's discuss about Burkitt's lymphoma. Now what is this? Even Burkitt's lymphoma, it's a neoplastic proliferation of B cells, but intermediate size. Okay, intermediate size B cells, which are also CD20 positive. Okay, now it is associated with what? It's associated with infections like EBV. Okay, associated with infections with EBV. See, if they want to ask a question on Burkitt's lymphoma, most of the time they will say an African child, who is having this lymphadenopathy. Okay, an African child who is having this lymphadenopathy in the jaw, the enlargement of the jaw. Okay, enlargement of the jaw. So what exactly is happening? Okay, let's see the important points. So let me write here. It's seen in African. Okay, African child with jaw involvement. African child with jaw involvement. Okay, which is called as African variety. Burkitt's cell lymphoma can be seen in Africans as well as in some other people also. This is called as African variety. In African variety, jaw involvement. Okay, jaw involvement is going to be there, enlargement of the jaw. There is something called as a sporadic form. In sporadic form, it involves abdomen. Okay, sporadic form is going to involve the abdomen. So what happens, sir? See, because of this Epstein-Barr virus infection, there is going to be associated with the Epstein-Barr virus infection. Okay, that's okay. But important point is these patients are also going to have the cytogenetic abnormalities. Okay, these cells are shown certain cytogenetic abnormalities which are the translocations. Translocations between what and what? Translocation between 8 and 14 chromosome. You know it, 14 is common for everything. 14 IgG, Okay, immunoglobulin. Okay, immunoglobulin heavy chain gene is going to be located. And chromosome number 8, what is located, sir? The c-MYC gene. c-MYC. Okay, c-MYC gene is going to be located. Now, what is the c-MYC? The c-MYC is something like a transcriptional factor which promotes the cell growth. It allows the cell growth. Okay. So, what is happening? In this patient, the cell growth is going to be too much over proliferation of the cells. Okay, over proliferation of which cells? B cells. The Epstein-Barr virus is going to especially affect the B cells. So the point which I want you to know is, sir, in Burkitt's lymphoma, the patient is going to have jaw enlargement because the lymph nodes are getting enlarged. Here the lymph nodes which are present in this region are going to be enlarged, so jaw involvement. So African child, in sporadic form there is going to be abdominal enlargement. Okay, so what is the translocation that is associated? Translocation is 814 translocation, which is going to cause overexpression of overexpression of c-MYC oncogene. Okay, c-MYC oncogene overexpression is going to be seen. Now, if you look at the histology, okay, if you look at the histology, see the histology is going to show something like this. See, there are lots and lots of intermediate size B cells. All these are the B cells. Okay, all these are the B cells. Now, in the B cells, see these cells, okay, they are getting too much proliferated, and some cells are going to die. Okay, some cells are getting dead. Okay, these cells are getting dead. So it just looks like a sky. In the center of the sky, you are having the areas, the clear areas, white areas. So it's going to classically called as a starry sky appearance. This is called as starry sky appearance. Okay, starry sky appearance is going to be seen in Burkitt cell lymphoma. So that's the important point which I want you to know. Characterized by starry sky appearance. So after this, next, let's discuss about diffuse, the large. We are going to the large cell. Okay, so diffuse large B cell lymphoma. So again, it's also lymphoma, but because of which cells? B cells only. The cells are going to be very large, immature cells, large B cells in the lymph nodes. Now, these cells, if I am talking about a B cell, that is also CD20 positive, no doubt in that. Okay. Now, out of all the different types of lymphoma, this is most common form of the lymphoma. Okay, most common type of non-Hodgkin's lymphoma is diffuse large B cell lymphoma. Where we have discussed about the diffuse large B cell lymphoma? Follicular lymphoma. If a patient is having follicular lymphoma, 14-18 translocation, that patients are at risk of developing DLBCL. In yesterday's class, CLL, chronic lymphocytic leukemia or small lymphocytic lymphoma, if the patient is having that, the patient is at risk of developing diffuse large B cell lymphoma. Diffuse, entire lymph nodes are going to be affected with large B cells. Okay, the entire architecture is going to be distorted. Everywhere is the large B cells. Okay, now what I want you to know is, so it's going to be present at late adulthood. Okay, seen at late adulthood. Okay, I have spared you. It is sporadically, it's sporadic, or it can come from transition from follicular lymphoma or chronic lymphocytic leukemia. Okay, see the prognosis is going to be bad. Okay, this is aggressive tumor. It is going to be aggressive, so it's going to have a bad prognosis, aggressive high grade tumor. Okay, so this is enough regarding the diffuse large B cell lymphoma. So with this, what we have completed? We have completed non-Hodgkin's lymphomas. Okay, non-Hodgkin's lymphomas are completed. Now all these non-Hodgkin's lymphomas, whatever I have discussed, these are high yield and all of them are because of the B cells. Now the classification is based on what? Size of the B cells. Okay, it's for easy understanding purpose. Okay, it's for easy understanding purpose. Small B cell lymphomas are 3: follicular lymphoma, mantle lymphoma, marginal zone lymphoma. Follicular lymphoma, 14-18 translocation. Mantle lymphoma, 11-14 translocation. Marginal zone lymphoma associated with the chronic conditions. One of the example is gastric maltoma. Intermediate size B cells are going to be seen in Burkitt's lymphoma, that is African child. African form is going to have the enlargement of the jaw. The other forms, okay, are going to have the abdominal involvement. Okay, the sporadic form is going to have the abdominal involvement. And what about the diffuse large B cell lymphoma? Large cells. It's seen as a transformation that is called as a reverse transformation. Yesterday's class I have explained. The CLL can become DLBCL. That's called as a reverse transformation. Okay. Now, rituximab is used for, it's an anti-CD20 antibody used for the mainly treatment of follicular lymphoma. Okay. So what are the two types of lymphomas, Hodgkin's and non-Hodgkin's? In all these conditions, whatever I have discussed, I haven't discussed about the Reed-Sternberg cells. Okay, Reed-Sternberg cells are not seen. Okay, Reed-Sternberg cells are not seen. But Reed-Sternberg cells are mainly seen in Hodgkin's lymphoma. It doesn't mean Reed-Sternberg cells are only seen in Hodgkin's lymphoma. No, even in non-Hodgkin's lymphomas also, whatever I have discussed, especially in diffuse large B-cell lymphomas, yes, in some of the varieties of diffuse large B-cell lymphomas, yes, Reed-Sternberg cells, okay, Reed-Sternberg cells are seen. Okay, so leukemic phase is not seen in Hodgkin's lymphomas, but in non-Hodgkin's lymphomas, whatever I have discussed, leukemic phase can also be seen. Okay, most of the time this non-Hodgkin's lymphomas, whatever I have discussed, most of them are extranodal involvement. Extranodal involvement is going to be seen. Okay, so with this, non-Hodgkin's lymphomas are completed. In the next video, I'll be discussing about the Hodgkin's lymphomas. Hope the video is helpful. Thank you.